Hello, everyone, and welcome to the final lecture on the metabolic code Triad system. Today, we will cover estrogen, progesterone, and testosterone, which typically forms the basis of bioidentical hormone replacement therapy. I'll be placing it into the broader context of the other four triads to show how these imbalances typically overlap in common ways with other related presentations. And then we'll talk about the details of basic bioidentical hormone replacement, since there are a number of strategies to employ that if you haven't done that already in your own practices. So what are the characteristics of this triad? I think when you consider what these hormones do for us, it's really varied. But on a higher level, for me, it's about potency in the world and feeling effective and vital. And certainly when these hormones are in balance, individuals have a sense of efficacy in their lives. So it relates, generally speaking, to self-esteem. It's important in terms of relationships, and for men, I think, from a gender-specific perspective, when they're in balance, we feel quite industrious and productive, and we're very reward-driven. For women, at their core, with respect to these hormones, it's about reproduction and security. And I think that's the sort of inflection, but of course, it's easy to see how you could scramble the gender distinction and really just say, in terms of influence of hormones, testosterone is really about sort of reward, and estrogen and progesterone are about sort of reproduction. So there's these sort of flavors that go with hormonal balance and kind of where they drive individuals with respect to how they feel in the world, and their behaviors. So I think this is a really important one. Obviously, we started the first week with just looking at some of the more recent review articles related to hormones in general and the discussion around is it safe? And I think it's hard to say for sure whether or not they are safe. Some of the longer-term bioidentical studies are up to 10 years, and the safety profile is quite high, certainly better than synthetic hormones. But the guidelines that are available to us really haven't shifted based on the distinction between the two sets. And you will still hear the comment that we should not distinguish with respect to the type of hormone, that if you're replacing a hormone, there's risk. And I think that obviously from our perspective, from the alternative medicine or integrative medicine community perspective, there's a voice within that community that argues that they are safer. I don't think anybody can say that they are completely safe. But I also believe that when you start talking about safety and segmenting, what does that really mean with respect to breast cancer risk, stroke, heart disease, that even with the synthetics, the risk profile has changed to some degree. I tend to, in some sense, hang my hat on Dr. Cavalieri's work out of University of Nebraska. I've inserted a couple articles for you with regard to that, and his opinion is that as he has tracked the production of the four hydroxyquinones, that these quinones directly damage DNA, and that's probably where the majority of the risk occurs. It's not within the 2:16 ratio, and I actually think that the data is relatively weak when it comes to 2:16, however much it's been promoted. That the data is far stronger with respect to the quinone production and the DNA adducts in the ways in which they disrupt normal DNA replication, and that the majority of the risk as it relates to estrogen influence is through that particular pathway. He's also shown that it's a pathway that's relatively easy to manage by having the patient take resveratrol and N-acetylcysteine. But this area certainly provides more heat than light, and I think, to some degree the jury is still out. My perspective is that we should put hormone replacement in the context of encouraging our patients to be healthier overall. I think we run into trouble if the individual has a poor diet, they're under significant stress, they're overweight, they've been exposed to toxins, they're inflamed. And when you think about that, that's a very kind of brief overview, kind of a high-level perspective on, well, what are the other 4 triads? And I always think when I have patients who come to my practice with an explicit agenda of hormone replacement, it's an opportunity to help them balance their stress, improve their diet, get them moving and breathing and detoxifying them and improving their digestion and immune status. That, you really should consider hormone replacement as part of a larger process. My sense is that if you put hormones into people that are already pretty sick, you're more likely to have bad outcomes. You're also going to have a greater difficulty in balancing those hormones. And in fact, my experience has been as well, there's this kind of bi-directional relationship between hormones and, if you want to call it, this kind of total body sickness. And that is to say, when someone is really sort of an extremist or their metabolism is disrupted in some way and they are sick, you're going to find a lot of abnormalities in their hormones. And I think the changing levels are due to these underlying issues, and that in some ways there was a thinking around, well, what is the 5th triad? And maybe we sort of, in a sense, put it last because we feel like in some ways it's the last thing we should do with patients. I also understand that as a construct, each of the triads are supposed to be equal in their importance, and they are. And the real art is to knowing where to start with respect to balancing an individual. But my caution is that you really focus on improving the person's health first before you begin attempting to balance their hormones. With that being said, let's get into, well, how does Triad 5 fit in the framework of the other triads, and how do we go about some basic hormone replacement? So what are the imbalances when these hormone levels are not in their optimal range? People can express low self-esteem. They tend to retreat from relationships. They're not as interactive or sociable. We know this is true for both men and women. And certainly on a more sort of physical and energetic level, there's that lack of libido and sex drive and need for physical intimacy and touch. I think certainly that ties into this notion of self-esteem, and after having done hormone replacement for years, to me that's true for both men and women. And in this instance then, I find that lack of intimacy, lack of healthy libido often stands at the core of problems within relationships, and is one of the major drivers in that regard. It's one of kind of a handful that many psychologists kind of focus on as part of disruptors in healthy relationships. So it's important to know, what is their hormonal status, and is there something you can do to help support that. There's this sense of loss of control and security in the world, sense of mistrustful, being impotent physically and emotionally, dependency and isolation. So as I said, it's people kind of retract from relationships, from feeling potent in the world, feeling productive and reproductive when these hormones are out of balance. So estrogen, progesterone, testosterone, they're important for both men and women, but I think it's the emphasis sort of in the levels between the two. We tend to, of course, talk about testosterone with respect to men, but of course that's important to women. And we tend to talk about estrogen and progesterone in women, but don't forget testosterone as well. But it's all about balance with this particular triad. So potency, self-esteem, and security, these are the typical expressions that people have with respect to an imbalance within this triad, and you want to encourage and nourish a sense of potency and esteem in the world and feeling secure in relationships and secure in one's life. So what are some of the common pathologic disturbances? Here are the most common ones. We typically see what would be called estrogen dominance, and that is to say elevated levels of estrogen with respect to progesterone, that they are not in balance, and this is really disruptive for an individual. Oftentimes, this is also seen in the setting of a lower testosterone too. So this is a classic imbalance that's typically leading to weight gain, depression, and fatigue. Lots of things will induce estrogen imbalances, but typically obesity and stress are the two biggest drivers in this regard. Certainly the presence of persistent organic pollutants and chemicals in general as endocrine disruptors will also do this too, although sometimes you'll see an elevated testosterone as well as an elevated estrogen. But estrogen dominance is a key feature for hormonal imbalance. This could also be due to improper metabolizing and disposition of estrogen, that if there's poor digestion and a sluggish digestive tract, a patient is not taking in enough vegetables and fiber, they're just recycling their estrogen in particular, so it's imbalancing the ratio of estrogen to progesterone and testosterone. Once again, this gets into, well, is Triad 1 imbalance? Is Triad 2 imbalance? Is Triad 4 imbalance? Because all of those can drive estrogen production. And even with Triad 3, if they're in sympathetic overdrive with decreased heart rate variability. So the end consequences is quite bad for the individual because there's sort of a symptomatic cost to estrogen dominance when we see this particular pattern of imbalance. And again, we can also see an elevated testosterone. So this is typically due to the presence of insulin resistance, so a PCOS pattern, as well as toxicity, so the presence of heavy metals and chemicals. So now we're beginning to invoke 1, 4, and 5 in particular as a expression, and sometimes you can see just if the patient is coming in with elevated estrogen and testosterone and a decreased progesterone, you automatically begin thinking about, well, what's going on in Triad 1, what's going on in Triad 4? Because insulin resistance and toxicity will drive a pattern of elevated estrogen and testosterone and begin to overtake a balance with progesterone. This is a classic pattern in young women who have PCOS, for example. We know by definition there's elevated testosterone. We know by definition they have irregular menses. Ironically enough, despite the label, the presence of ovarian cysts is not required for the diagnosis, although that's typically present. And so when you're looking at these individuals, especially young women who present with PCOS-like symptoms, skipped or irregular menses, overweight, hirsutism, depression, I really drill down to 1, 4, and 5, and all of a sudden these young women begin to make lots of sense to me. So what would we see in patients that present with a Triad 5 estrogen dominance with an elevated testosterone and they're stacking their 1, 4, 5? Well, weight gain, depression, fatigue, and irregular menses. Triad 1, you're going to see the presence of elevated blood sugar and insulin, usually depressed free T3, often below normal, as well as the presence of toxins, whether it's gluten, organic pollutants, or metals, as well as more directly an imbalance in the ratio between estradiol and estrone. So we see an over 2-to-1 ratio with estrone to estradiol. So as estrone levels climb, and really estrone should be about half of estradiol. When estrone, and this is by serum, When it's above half, so basically in the serum, if estradiol is 50, you want estrone to be 25. If estradiol is 100, you want estrone to be 50. But estrone, as estrone levels climb in particular, it's a strong sign that they're becoming estrogen dominant. But you'll also see just very elevated levels of estradiol, but it's also the ratio too. I often see a reversal of this. So there might be estrone of 150, but in an estradiol of 50. In addition, for progesterone, you want a less than 20-to-1 ratio of estradiol to progesterone by day 18. So you want, a progesterone level of about 5 to an estradiol of 100. And then finally, you'll often see these patients with a testosterone at the upper limit of normal or above. So this is where we get into the stacking phenomenon. All of a sudden, these pieces should start to fit together for you and say, oh, I get it. I remember adrenal thyroid pancreas. It's about stress, metabolism, and sugar. So when the diet is too carb heavy, the individual's under stress, the T3 pools are dropping, they're gaining weight, they're tired, they're depressed, they're not sleeping well at night, and they have the presence of an accumulation of heavy metals or chemicals or other exposures. So this is accelerating their weight gain. They're starting to stagnate and inflame. We just covered this over the last 2 weeks. So this creates an additional pressure on Triad 1. And then finally, we see the expression of this through Triad 5, which is estrogen, progesterone, testosterone. This is a classic presentation. So Stacey King, 18-year-old senior in high school, has had trouble with self-esteem due to weight gain, acne, and excess hair growth. So this is why I put in this notion of self-esteem. It happens in the context of the imbalances of these metabolic processes. And so I think we can all relate to when we don't feel well about ourselves, and especially when our hormones are out of balance, that again, we sort of lose a sense of self. She finds comfort in food and her 4 cats. She complains of foggy thinking, painful heavy periods when they occur, which is less often than not. Is not interested in college because she, quote unquote, just does not want to deal with making new friends. She's living at home, which is just fine with her. And this is a real patient of mine. This is someone who I, didn't have to think too hard about. And you could see why this is a person who's retreating from the world. She doesn't feel good about herself. And physically, she doesn't feel well, too. So what's another common pathologic disturbance? Well, again, here's an estrogen dominance pattern: weight gain, depression, fatigue, low libido, and infertility. But now we begin to invoke the presence of Triad 3. This is an individual who not only has abnormal cortisol levels with respect to stress, but they're also in that sympathetic overdrive. And so, and there may be a background of 4 too, a Triad 4, with respect to exposures, especially with the low libido and infertility. You just never know what's sitting behind these people. Is it really lifestyle factors through Triad 1? Is it a deeper disturbance with respect to Triad 3? So this is an individual who's inflamed and in sympathetic overdrive. Or has this person encountered exposures? Are there methylation defects or other genetic restrictions where they're accumulating toxins that's really begin to impair the balance between estrogen, progesterone, and testosterone? If we go back to Peter Limpman, he looks just like this presentation, but there's an underlying metabolic disturbance that you have to be attuned to. So what are the symptoms that these patients typically present? Weight gain, depression, fatigue, low libido, pause, menopause, andropause. So this is a nice model then to say, boy, now I understand why these patients can be so hard to balance with respect to their hormones, because there's a lot of stuff in the way that I need to clear up. And this is what gets confusing even to seasoned physicians, because they're trained to just replace the hormones. If it's low, raise it. If it's high, lower it. But they don't make a lot of progress, and it's because the underlying metabolic machinery is impaired. So what might you see in someone like this? Well, again, same pattern with respect to hormonal imbalance, but when you look at the other triads, elevated cortisol, elevated insulin, with respect to Triad 2, food sensitivities, immune dysfunction, or even autoimmunity. Triad 4, we can identify exposures, whether it's candida or mercury. We've talked about this and how to deal with those issues. And what do we do? So, all of the hormones could be low if they're in menopause, or even there's some estrogen dominance. That would be a typical presentation as well. So this is something that you have to deal with with respect to replacing hormones, and it's not just about giving back estrogen, progesterone, testosterone. So 1, 2, 4, 5. So Barbara Hiltz, 52-year-old executive for a large insurance company who's losing her edge at work. Her cognition, memory, and creativity have been in decline for the past 2 years. She's experiencing night sweats that awaken her due to drenched sheets, and she struggles to fall back asleep. Her waist has grown slightly, and she can't seem to shake the extra pounds like she used to. Her PCP recommended a bone density test done now that she is postmenopausal, although, here's my family medicine stepping in saying, well, now the new recommendations are 65 or above. But, I know physicians that are still ordering that in cases like this. And she's been trying to drink extra milk to get more calcium. Barb has a history of fibrocystic breast changes, but otherwise is very healthy and active. She used birth control pills throughout her youth, but otherwise has not used hormones. Her relationship with her husband is flat, and carbs are her growing source of comfort. She admits to cravings and has become a night eater. Boy, so you can really tell, you can hear Triad 1, you can hear Triad 2, you can hear Triad 5, and the question is there even a 3 or a 4 going on with her in terms of cardiometabolic issues or toxicity? You don't hear that a lot, but it could be sitting in the background a bit more silently. But you're almost willing to guess that you're going to find imbalances in 1, 2, and 5, without a doubt. So what would you see with the Stacey King? So let's go back to the earliest imbalance. This is the younger woman who's complaining of irregular menses, PCOS type picture. She doesn't want to go to college because she's gaining weight. She has acne, PMS type symptoms, and she's withdrawn socially. So what do you find? Well, her fasting blood sugar is 103, well above our cutoff of 84, let alone 90. And so she's already crept into that true metabolic syndrome range of 100 or above, and she probably would begin to meet criteria in that regard. Her cortisol levels are very, very high. Serum at 22. We've gone through this with respect to, well, how do we better measure stress? Well, you could do your psychological inventory. You could do a saliva cortisol test, which we've covered, and now you know about that cortisol awakening response, or what are normal or abnormal patterns. You could do heart rate variability testing with her. So there's all sorts of things that you can drill down now with respect to her stress response. Her T3 pools are below normal at 1.9. She has the presence of autoimmune antibodies, which isn't surprising in a patient like this, probably driven by her exposures. You can see she has lead and cadmium, and she's got an HLA predisposition, DQ2, DQ8, for a genetic sensitivity to gluten. Now, that's not 100%, but it's relatively high. And so she's got toxic exposures, lead, cadmium, and gluten. I'm putting gluten in Triad 4. You could say Triad 2, but I'm saying Triad 4 in terms of a pressure on her immune system, which is why she's blossoming into autoimmunity. So she's got an imbalance in Triad 1. She's got an imbalance in Triad 4. And when you look at her labs, her estrone is 300. And say, oh my God, that's so high. And it is. It is. And it just reflects the total body burden of a chemistry that is not able to handle the exposure. She's under lots of stress. She's carb intolerant. And she's likely not disposing of her estrogens appropriately through her liver and kidneys and digestive tract. This is why we've covered Triad 4 first. How do we drain the swamp? Well, now you know how to drain the swamp. There are lifestyle-related issues. You want plenty of sulfur-containing compounds. You want to check her methylation pathways. You want to ensure she's taking in plenty of vegetables and fiber, ensure the liver and the kidneys are functioning properly. You may even want to add in some drainage remedies to get her going because she's exposed. And that's being reflected in problems in her estrogen, and if you look, problems in testosterone, which is classic. I have found if you can correct the toxicity as well as the insulin and glucose issues, that testosterone will start to come down. I've been amazed at how reliable the model of 1 and 4 are with respect to seeing a PCOS type picture in Triad 5. And typically speaking, they have very low progesterone. So what's the clinical strategy? You want to break her insulin resistance and manage cortisol and thyroid. You want to assess for toxicity in Triad 4 and balance her estrogen to progesterone ratio. So dietary advice, you know you're going to need to get the carbs out, no grain, dairy, or gluten, 1 to 2 servings of low GI carbs if she has evening cravings, but generally just a low carbohydrate diet. We've seen this before with respect to insulin management. You want to really load in the vitamins and minerals. Make sure she has a climbing pH above 6.5 or even 6.8. So this is where, as we've thought about, well, how do we progress learners through this process and where are the points of overlap? Well, when you replace minerals and vitamins, you're preparing the body for detox, and yes, you're restoring normal insulin signaling. So you really want to push the magnesium, the chromium, and the vitamin D. If she's got a very elevated insulin with an elevated cortisol, you might want to go a little more aggressively with an alpha lipoic acid or a bergamot, and then finally, if they have diabetes, a bitter melon, bergamot, cinnamon, resveratrol. Key concept: if a patient's not losing weight after 60 days, you want to add some fish oil or plant sterols and sterolins like a Moducare to decrease that peripheral inflammation so she can get that free fatty acid shuttling benefit. For thyroid support, subclinical hypothyroidism, yes, of course, her T3 levels are low. She's depressed, she's fatigued, she's gaining weight, so she's going to need some support. So selenamethionine iodine and maybe a glandular, but remember she's got presence of TPO, so you're going to want to do something other than that. I think in this patient, sometimes a Cytomel or a liothyronine would be a good choice for her. You want to check ferritin levels and replace if they're low. Key concept: this is a patient who's going to need a lot of chromium because, again, you're going to need to manage her insulin and you're going to need to manage her thyroid. Chromium is required for conversion of T4 to T3. So don't forget that while chromium is so important for insulin, it's also important for thyroid. Stress management for elevated cortisol, if yes, with mind racing at night, theanine. If no, if it's just elevated cortisol during the day, Relora, so it's magnolia philodendron, 1 capsule 3 times a day, holy basil, 1 to 3 capsules daily, phenyl GABA, which is very good but a little more sedating, and then you can always add in some theanine on top. Key concept of insulin resistant cravings and stress, then add tryptophan, 500 milligrams 3 to 4 times per day. If there's GI inflammation, signs of symptoms of yeast, and you would worry about that with her because there's the presence of sugar. If there are known toxins as well, cat's claw with oligomanganese copper, and then with the presence of toxins, curcumin, because that helps to dispose of cadmium and support the kidneys. So this is a patient who you might want to invoke Triad 2 depending on her symptom. In terms of environmental chemicals, we've covered this before. If you measure using a US Biotech or a Metametrics panel, which I think they've combined with Genova now, if they're present, and certainly, again, as I've mentioned, is this a patient who looks like she's got some endocrine disruption? I would say yes. It's sort of red flags everywhere with a PCOS type picture. Chlorella, glycine, taurine, lipoic acid, and some D-Jex-like quiescence. You could also add in that infrared sauna, dry brushing, detox baths, foot baths, whatever you decide, but this is the core. If access to infrared sauna, utilize 3 times per week for 20 to 40 minutes, preload with niacin, arginine, and green drink. So if you think they're heavy metals, so DMSA, again, this has been pulled from the market, but you could have this compound of 3 capsules, which is a total of 750 milligrams at night, 3 days out of 14 or 2 days out of 7, so I usually do Saturdays and Sundays. Chlorella, 2 caps twice a day throughout the week, a multivitamin with a mineral support, like a powdered mineral with like coral legend, a quarter teaspoon twice a day. And then you want to add in either aged garlic extract or lipoic acid in addition to the DJEX for drainage. You can also add in EDTA suppositories. You could do that in lieu of the DMSA or in addition to. Generally speaking, anywhere it's from 750 to 1,000 milligram suppositories 3 nights a week. Again, I like EDTA suppositories. You can also combine with DMSA. Again, you want to ensure the metabolic support. And if they're really, really sick and you're just concerned about pulling heavy metals out, you can also do the IMD resin, which works through the vasculature of the bowel. It's expensive, but it works really well. So it's 1 scoop daily, 5 days out of 7. And that's through Mountain Health Products, Quicksilver. So Triad 1, 4, and 5. That's what this patient is. She's young. She's got a lot of issues. She's sicker than we would like her to be, and it's not just about giving her birth control pills. I know that's the standard, plus spironolactone to try and knock down that testosterone, but she's got deeper issues, and you're really going to have to work with her over time, but I often find that these patients are pretty committed. So what would you do with her for Triad 1? Caveman diet, multivitamin mineral, chromium, lipoic, magnesium, and D, some magnolia philodendron, selenium methionine iodine, and some liothyronine. For Triad 4, I'd get her going on chlorella and some DJEX liquescence, and at some point you're going to want to go heavier in terms of getting rid of chemicals and heavy metals, and especially the heavy metals. She'll benefit pretty well. But first you want to gain control of the lifestyle issues with Triad 1. Manage her stress, manage her diet, manage her thyroid. She's going to start feeling a little bit better, losing some weight. And once you get that pH up and running, and that's the signal to start doing some chelation therapy with her. And she'd do very well with, I think, a combination of DMSA and EDTA. At some point, you may want to measure, genetic detox pathways, at least an MTHFR, seeing if she needs some additional support. And then as far as her Triad 5 goes, and I'll go into this later, because her estrone is high, diindol methane, so DIM, usually it's 150 to 300 milligrams at night. You may want to support her progesterone in the meantime with a topical 20 milligrams, days 7 to 25 of the cycle, and then some saw palmetto to block down on that testosterone. Peter Limpman, he's our stressed out 37-year-old detective, weight gain, low libido, fatigue, and lack of motivation. He's driving the desk now. So he's not as active, he's stressed from sitting, he's stressed from interoffice politics, and when you measure him, his total testosterone was basically unmeasurable. It's below 250, which, how many young men do I see with this? But also when you look at his other patterns, his fasting blood sugar is 110, he's flattened his cortisol curve, his blood pressure has an uptick of 135 over 85, but maybe more importantly, he's got an elevated resting heart rate of 82, which is way too high for him. Remember, our basic cutoff on the literature is 76. I think it should be even lower than that, but 76 seems to be where the real heart disease risk is. His high sensitivity CRP is 5.5. His total cholesterol is 250. He's got the presence of lead. He's a total setup for cardiometabolic disease. He is the actual risk. So when you look at the data on the complex of factors that drive guys in particular down the road to heart disease and diabetes, he is exactly what we would see. Now, with that being said, if you ran standard labs on him, you'd see, yeah, sugars are a little elevated, probably would have missed the testosterone, certainly isn't going to measure the cortisol. Yeah, his blood pressure is a little high, but you might write that off saying, well, it's in the office. His total cholesterol, you may want to consider starting him on a statin if you have a pretty aggressive physician, which would probably worsen things because you know now that statins deplete testosterone. It's just going to make things worse. His estrone levels are very high. You want them below 50 in men. So this is a guy who would get missed, and yet he is absolutely marching down the path. His sugar's high, he's got a flattened cortisol curve, and he's got a low testosterone. And when you look at the data, that is the triumvirate. It's sort of a male triad of insulin, cortisol, and testosterone that is an enormous risk for developing heart disease, and he is exactly that. So he's a 1, 3, 4, 5. So who qualifies? Anybody for testosterone replacement, anybody below 250 is consistent with a health risk. If they have concurrent diabetes or blood sugar issues, it's below 350. The optimal range is 500 to 700. There's actually some data to suggest anything above 700 actually can accelerate plaquing in the arteries. So you want to be careful about that too. I know that guys really like to push the level to, they feel they're best at 1,000 or 1,200, but I think there are some issues with that. You always want to measure a morning specimen. You want to assess for total testosterone at baseline, and then follow in replacement with urine or blood spot for topical, and then also it's okay to follow serum with injection or Clomiphene or Clomid or even HCG. But if you're doing topical, you really can't do blood. So, for years I used to do saliva. You'll notice that that's sort of conspicuous by absence. I think saliva is pretty inaccurate. So I'm not a big fan of saliva testing now, both for men and women. When you, and this is one of the reasons why we had you do your own urine instead of saliva. And it was merely to raise the discussion that the technology that's now available to measure hormones is quite good, and urine is probably the best specimen now, closely followed by blood spot, which is a finger prick. And I think saliva, you can get a lot of variability with individuals, and I'm not a big fan of saliva testing anymore. I saw too many screwy results with patients. So LH and prolactin, these are both important hormones to measure in men when you're considering what their testosterone levels are and whether or not you're going to replace. It helps you determine, is it primary or secondary hypogonadism. The LH should be 5 or better, which means that it's resistance at the secondary level. If it's above 5, then you can do Clomid or HCG. They're likely to be ineffective because the testes are not responding. So whether or not you give an LH analog like HCG or Clomid, you're not going to get the bump. If the LH is really low, it's likely a pituitary issue. And so if it's centrally mediated and the testes are working normally, then in fact you're going to get a good bump with Clomid or HCG. Normal prolactin range is 3 to 20. We prefer to see a lower value of 5 or so. If it's elevated, you need an MRI to rule out a prolactinoma, and testosterone is contraindicated in these patients. So this helps to determine where they're at and whether or not it's a brain-related issue or a peripheral issue. So International Society for Study of Aging Male, they offer guidelines. There are actually lots of organizations that do. There's also the American Society for Men's Health. If there's BPH causing bladder outlet obstruction, it's a contraindication for testosterone replacement. In general, I disagree with BPH, and I often find the reverse, that with healthy levels of testosterone, we often see a restoration of prostate as opposed to an increase. And actually, both in the issue of hormone replacement with respect to enlargement of the prostate as well as risk for prostate cancer in men, when you go to the American Society for Men's Health website, they will explicitly say under almost all circumstances there just does not seem to be an increased risk. Despite what recent discussions have been, despite some of the recent studies which really were terribly designed, they never should have been published. There's well over 20 years of data now to show that there is no link between testosterone replacement and prostate cancer, and all of the world's top testosterone researchers will say the same thing. Unfortunately, that's not the climate that we live in, and I have a suspicion that if we really looked at bioidentical hormone replacement in women, we'd probably come to the same conclusion. There just aren't the same length of studies or size of studies in women with bioidentical. And interestingly, there's such a distinction between those two communities with respect to the safety profile and discussion, where the men's health community says testosterone is great and it's healthy to replace with really no risk, and then the women's health community is saying just the opposite with respect to hormone replacement. So, and I think it's mostly because women, unfortunately, have been treated mostly with synthetics. Men have been treated mostly with bioidenticals. So what are some causes of androgen deficiency? Well, the brain. So age, stress, drugs. in particular with the hypothalamus and pituitary. Again, age, lack of GnRH, prolactin and drugs in the testes, age, poor development, infections, alcohol, diet, diabetes, trauma drugs, temperature, stress. So target organs, age as well, receptor anomalies, downregulation of receptor activity, and then drugs too will do it. So stress and tone, sympathetic tone. Physical or mental stress alters the HPA axis. We know this. Self-esteem will directly affect production. Overactive sympathetic nervous system will reduce production and response, and stress may increase prolactin levels. So, here we have a direct impingement on Triad 1 and 3 on Triad 5. So what happens under stress is inflammation or stress goes up, cortisol levels go up. That's on the innate side, and then as inflammation levels continue to climb, cortisol levels will go down, which is even worse. Increased cortisol blocks conversion T4 to T3. We know this. TRH to be upregulated to create more T4. Increasing TRH will increase prolactin, which in turn downregulates LH and FSH. So as you get this sort of intra-triad response, you get these inter-triad responses too. So in turn, you get a downregulation of testosterone. And as testosterone goes down, so does growth hormone. So stress and thyroid abnormalities from Triad 1 can create significant impact on Triad 5. And then to make matters worse, I talked about this, especially in men, there's lots of data to suggest when you have abnormalities in cortisol and testosterone, we can see a direct impingement on blood sugar and insulin. And when you look at those long-term studies, the major clinical risk is heart disease, but the thought is most of that risk is triggered by or induced by insulin resistance. So here's an example of one of those studies, a 5-year follow-up study of disease incidence in men with an abnormal hormonal pattern. And they looked exactly at this, a cortisol to testosterone ratio driving cardiometabolic risk. And here's a second study, and this is very interesting. So I'll just read the conclusion. This is the first population-based prospective study that has found a specific association between cortisol to the testosterone ratio and incident ischemic heart disease. But apparently, this is mediated through the insulin resistance syndrome. So whether this reflects the effects of chronic stress, behavioral factors, or genetic influences remains to be determined. This was just in 2005 in Circulation. The notion that Triad 1 imbalances and Triad 5 imbalances are interacting with each other. Amazing studies that come out on these relationships, and I'm always delighted to find them in the literature because I think this is how we should be looking at our patients' physiology. It's not just about testosterone or insulin or cortisol, it's the ratios of these things, and that's the whole kind of notion of the kind of crosstalk that we see within triads. And these beautiful studies begin to articulate how the body has this set of crosstalk, and that when it sort of piles one abnormality on top of the next, we begin to see real clinical illness arise over time. So what are the labs required for men with testosterone replacement? You want to get an estrone and estradiol. You want to keep them both in the 20 to 50 range and make sure that they have a normal ratio. Again, you want about a half estrone to estradiol. Dihydrotestosterone, so testosterone converts into dihydrotestosterone. You want to keep this in mid-range. Dihydrotestosterone is the active metabolite of testosterone that works at the level of the receptor. And there are some treatment studies looking at replacing with dihydrotestosterone instead of testosterone, which is interesting. PSA baseline, free PSA is only if above 2.5. Other labs, I mentioned this, LH and prolactin. You want to get Triad 1 panel, Triad 3 panel for lipids. You want to monitor their CBC because when you do testosterone replacement, the hemoglobin and hematocrit can start to climb. If everything else is normal, and they seem to be in a good range, but they have an elevated hemoglobin and hematocrit, they can always do some blood donation to get that down, and then follow just a Chem 17 panel as well. So if their testosterone is low overall, if it's below 350, really, and their LH is above 5, this is primary hypogonadism, meaning it's the testes that are not responding to a persistently elevated LH. If it's a low LH, a luteinizing hormone, then it means this is at the level of the brain. So secondary hypogonadism, most common finding, and this means that you can stimulate with an LH analog like Clomid or HCG. I'm a big fan of Clomid. I think it works quite well. It also helps to modulate the stress response. People feel pretty good on Clomid. Also, when looking at prolactin, 3 to 20 is normal. If it's above 20, you need to do an MRI. You also want to look at how old is the patient. There are no good cutoffs for this. We've chosen age 55. You could say in your mind age 50. There are no diagnostic criteria, but basically when they're reaching that area where they're losing their body's ability to produce testosterone, you need to decide, are they really a reproductive male or not? That's what this is meant to indicate. If you feel that they're a reproductive male and you think that their testicles are still able to produce androgens, then you want to rejuvenate them. And you can do that with an HCG, a Clomid. You can also do a pituitary complex like eco-pituitary. This comes from Professional Health Products. It's a pituitary glandular. And also zinc. Zinc is very important for not only mobilizing testosterone receptors, but also helping the body produce testosterone. If they're a non-reproductive male and you want to replace, you have lots of options in terms of creams and patches, pellets and injections. If they're under 55, or again, if they're a reproductive male, you can do HCG, and this can be applied in or administered in all sorts of ways. You can do a topical cream of 200 units daily. This is compounded. You can do a subcutaneous injectable, 125 units daily. You can also do 600 units once to twice a week. So that's the other way. And some people do even 3 times a week at 600 units. You can also do a recombinant HCG, 250 micrograms reconstituted to 1 cc. So there's lots of options here. Some guys like the daily, but they don't want to do the injection. They get a good response from that. You can always switch them over to the 600 units or cream. HCG topical cream, 200 units per gram daily. Apply to torso, arms, or thighs. Adjust 50 units every 12 weeks. If you want to do the sub-Q injection, 125 units sub-Q daily, or 600 units 2 to 3 times per week, and adjust in 25 to 50 units every 3 months, and then the recombinant as well. You also want to check their labs in 3 months. So you want to check their testosterone levels, their hemoglobin hematocrit, their estrogen, estrone and estradiol, as well as their dihydrotestosterone and sex hormone binding globulin. Remember, HCG is centrally regulated. So you're basically going to max out around 700, and that's what I see in a lot in men. You want to check blood levels in 3 months and adjust dosing, monitor estrogen closely, and if no significant change after 12 weeks, you can increase the dose. What do we do about the pituitary if it's low? For LH, which is the most common, it's less than 5, you need to regulate pituitary function. So yes, you can do HCG or Clomid, but you can also add in the eco-pituitary or the pituitary complex, 1 in the morning and 2 at night. Pituitary liquescence, a half teaspoon twice a day, and then check heavy metals. For testosterone support, zinc 40 milligrams daily to support testosterone production. Higher protein diet, 0.75 grams per pound of body weight. Avoid alcohol, moderation is okay, and avoid xenoestrogens, plastics, pesticides, herbicides, glue, solvents, so on and so forth. So Triad 4. What do we do with an elevated sex hormone binding globulin? Sometimes you see this. So when you start replacement, that SHBG starts to go up. If it's elevated, you're a coma. We've talked about this. This is Tongat Ali or Long Jacks, 400 milligrams once to twice a day. Rubus, which is a homeopathic remedy, 25 drops 3 times a day. And then you can also do an anastrozole sublingual troche, 10 to 20 milligrams daily, or you can do 0.5 milligrams of Arimidex as well, which I've seen work too a little bit, but anastrozole is quite good. But sometimes it'll kill the sex hormone binding globulin and it'll go too low. But you have a number of options, and you want to monitor every 3 to 6 months. How do you manage dihydrotestosterone? About 7% of testosterone is converted to dihydrotestosterone by 5-alpha reductase. There are a couple different enzymes in this regard. Type 1, skin, liver, and brain. Type 2, prostate plays a role in BPH and cancer. You want to keep the levels in mid-range. It drives sexual function and cognition. Testosterone is really a pro-hormone, and dihydrotestosterone is the power. So dihydrotestosterone serum levels, if they're low normal, they're fine, so you just want to monitor with replacing. If they're high normal, saw palmetto, which blocks 5-alpha reductase, 160 milligrams twice a day. I like ProstaShield. There's all sorts of products in the market. Rubus will do it, zinc, and then finasteride. Yes, as a 5-alpha blocker, you don't need to do it every day. You can do 2.5 or even 5 milligrams once to twice a week, and that's usually enough to block down on DHT and keep it in that normal range. What do we do with estrogen? For estradiol, 20 to 50 nanograms per ml is the goal. If it's elevated above 50, then you want to evaluate for symptoms, probably aromatization, maybe gynecomastia. You may even want to check the prostate just to be safe. If the estrone is equal to you want to keep the estrone or equal to or less than estradiol, and if estrone is greater than estradiol and certainly above the upper limit of normal, diindole methane, 150 to 300 milligrams at night. If estradiol levels are climbing, you want to do an aromatase inhibitor because aromatase is the enzyme that converts testosterone to estradiol. You can do DIM and zinc, and then anastrozole, 0.5 milligram twice per week, and that works really well to block down on estradiol, and then recheck in 3 months. So aromatase blockers, again, anastrozole because it's reversible binding, 2 to 3 day half-life, so dose sparingly. So basically you can do once or twice a week. 0.25 to half can be compounded, comes in 1 milligram. You can do 1 milligram once per week, and I find that works too. If estrogen levels are too low, it'll reduce libido. If it's really low, it can trigger coronary calcification, so you want to control it, but don't kill it. Clomiphene. So clomiphene is a SERM, a selective estrogen receptor modulator. It increases gonadotropins by inhibiting negative feedback on the hypothalamus. 25 milligrams so you can do a challenge to see if they respond to clomiphene. So 25 milligrams in the morning for 7 days. Check LH, FSH, at 8 a.m. on day 8. If there's a rise in hormones, then it works. And you can do Clomid 50 milligrams twice a week. And I do often 3 times a week. So and I'll have guys do 50 milligrams at night, Monday, Wednesday, Friday. And I find that it works really well. So this is the challenge. And if it works, you can choose, am I going to do clomiphene or HCG? Or you can just stick with the clomiphene. And do I do this forever? Well, remember they're reproductive male. It's interesting that as you correct the other triads, it may very well be that they only need to be on clomiphene for 6 months or even a year. And oftentimes this resets that HPG axis, and then they don't need it. What do I do with testosterone treatment itself? You want to start low and move slow to avoid tachyphylaxis and avoid side effects. Do labs every 3 months. Which gives time for the sex hormone binding globulin to adjust to new hormone exposure. And then you want to monitor those metabolites and reactions. Dihydrotestosterone, sex hormone binding globulin, estrogen, and a PSA. So what do I do? If it's a cream or a patch, so this is topical testosterone, you want to start 10 to 20 milligrams daily, and then 20 to 50 milligrams after 6 weeks or so. Lab in 12 weeks, you want to keep it above the belt and rotate sites, chest, abdomen, flank, and shoulders. If you choose to do the traditional injections of IM or sub-Q, it's 150 to 200 milligrams per ml. I think cypionate is the best, and it's typically the most widely used. It's an injection of 1 cc every 10 days to 2 weeks, and you want to draw level 1 week after injection to make sure they're in the kind of 500 to 700 or 800 range. You can also do pellets. You'd have to get specifically trained in that. Typically, the pellets are inserted, and they're in place for 3 months or so. You can also sort of microdose with sublinguals and troches just to give a little extra testosterone throughout the day. These are physiologic spikes, but they're not adequate as primary treatment. You can do sublingual drops, 1 to 2 milligrams, 2 to 3 times a day. A sublingual troche, dissolvable, 5 milligrams, 1 to 2 times a day, or even a sublingual tablet, 5 milligrams, 1 to 2 times per day. So there are lots of options with respect to testosterone replacement. And some guys just respond better to one or another. I used to do a lot of creams, but I found that sometimes gels are better than creams, or old school injectables. Sometimes guys just really end up liking that the most, even though they don't like the idea of an injection, which actually are not that hard to do. And because they're dosed every 10 days to 2 weeks, it's not that difficult. But the route that you choose to replace also determines how you test. And as I mentioned before, if you do a cream in particular, you're really going to need to do urine or a blood spot. If you do injectable, you can do serum. If you do a patch or a gel, serum isn't that bad, but still I think that urine or blood spot probably is better than even saliva. So for all patients, you want to do DIM once daily, so 150 to 300 milligrams, and zinc 40 milligrams, saw palmetto twice a day, a higher protein diet. You really want them getting to move. We've talked about this in 6201, and that is to say a higher intensity, which helps guys burn fat. It raises testosterone and growth hormone, and then you want to check every 3 months until stable, and then every 6 months for a year, and then yearly. Those are the guidelines for how you follow in this regard. You can also check a PSA velocity just to make sure the PSA levels are not climbing too quickly. So it's you do 2 points in time. You minus the first over the second over the number of days, and then you times 365, which gives you a velocity. Between 0.5 to 1.3 is concerned for cancer, and if it's over 1.3, it's most likely prostatitis. So here's an example. 54-year-old male started on topical testosterone. His starting PSA was 1.2. His ending PSA was 1.8. His rise of 0.6 over 109 days was 2.01. So this is prostatitis. And you can send for a urology consult. I wouldn't stop for testosterone, but that's how you do it. So what do you do for a guy, 37-year-old, under stress, low testosterone? How are you going to manage him? Well, you want to focus on Triad 1. You want to break that insulin issue and manage his cortisol and thyroid. You want to assess for cardiopulmonary risk, which he clearly has, evaluate for toxicity, and then balance his testosterone and estrogen. Get the carbs out of the diet. Support his insulin receptors. Replace minerals and nutrients. And depending on the degree of blood sugar problems, you can get more and more aggressive. Remember, you want to support a stress response. I like adaptogens. You can also do glandulars, but remember, I say go cautiously with that. If patient reports difficulty sleeping, add neuromedulla at night to reactivate the hypothalamus. Dyslipidemias, again, for cardiometabolic risk. Red yeast rice, and recall that probably the dosing should be at night. I mean, you can do twice a day. That's what all the studies do, but actually the HMG-CoA reductase receptor is most active in the evening, so that's when you really want to block it down. And the dosing for red yeast rice is 1,200 to 4,800 milligrams. If he's got an elevated blood pressure, you want to screen for heavy metals. Again, that's a Triad 4 issue. Now you know how to do that. Insulin and stress, theanine for stress and blood pressure, magtaurate to bowel tolerance. Again, the taurine component is quite good for the heart. If it's 130 over 80, you can add H-garlic, arginine, hawthorn, milk peptides, and then if it's over 160 over 90, new guidelines are an ACE inhibitor, like lisinopril. Elevated HS-CRP, if it's over 2, H-garlic, 3, fish oil, over 4, add green tea extract. Key concept, if patient has elevated CRP and heavy metals, you want to add some curcumin to protect the kidneys. You know how to do your DMSA chelation. We've talked about this. So 3 capsules at night, probably Saturdays and Sundays, chlorella, multi, H-garlic, and lipoic, and then DJEX. You can add in that suppository for EDTA 3 to 4 nights a week in addition to the DMSA, or resin 5 days out of 7. Key concept: if ongoing sleep, stress, and borderline chronic kidney disease, add cordyceps and melatonin. And so here we have stacking: Triad 1, 3, 4, 5. And that's what he represents. And even though it was stress and low testosterone, he's got a lot of stuff going on. So what would you do for someone like him? For Triad 1, get the carbs out of the diet, replace minerals and nutrients, chromium, magnesium, and D, maybe an adrenal glandular for his low cortisol, and some cordyceps for his ongoing stresses and adaptogen, because we know he's had some exposures, and that's going to help protect his kidneys. Triad 3, H garlic. Remember, that lowers homocysteine 2. It's incredibly protective for the cardiovascular system. Some curcumin for inflammation and arginine for his blood pressure. Triad 4, you're going to need to start detoxifying him with EDTA, chlorella, and Dejex liquescence. And then Triad 5, to get his hormones back in balance, some DIM. You could do HCG or Clomid, and then some zinc at 40 milligrams. So you can see how this is all starting to come together in the way that you would manage someone like this, who's under a lot of stress, and he's got low testosterone. There's a lot more that would need to be done, but he's going to feel really good, I guarantee. And he did. You know, he lost weight. We chelated him. We balanced his hormones. He felt really well. And then finally, Barbara Hiltz, Triad 1, 2, 4, and 5. She's our menopausal female. Sugar cravings, fatigue and stress, loss of security and boundaries. So she's working very hard. She's traveling a lot. She's gaining weight that she can't lose. She's always been healthy. She's never done any hormone replacement. But when you check her, you know that her cortisol levels are high, insulin levels are high. She's got food sensitivities and the presence of TPO antibodies and candida and mercury. And she's in menopause, right? So her estrogen, progesterone, testosterone levels are low. So you know that you're going to have to replace her, but you really got to work on 1, 2, and 4 in addition to 5. So what's the protocol for hormone replacement? This is how I do it. I think this is very reasonable. I'm not terribly aggressive, but again, I have found when you balance the person overall and you get them healthy, you don't need to give them a ton of hormones. I see lots of people overdosing all the time. So I start with progesterone for 2 to 4 weeks before initiating estrogen. So I begin to reverse some relative estrogen dominance, which most people have. We want to do the diindol methane, DIM, initiated to ensure proper estrogen metabolism. It's a must during BHRT indefinitely. I also would add in resveratrol and N-acetylcysteine. This is really based on that work by Dr. Cavalieri. I think those 3 together are so important, in addition to kind of the general approach of you got to turn on Triad 4 and get those drainage sequences moving properly if you're going to replace with hormones. You don't want the liver to metabolize things abnormally. You don't want hormones to get stuck in the gut and recycled. You really need to make sure that all of the drainage pathways are open and moving properly. And then during this time, patient is to undergo regular screening. So how do I do my dosing? Topical production of progesterone is 20 to 30 milligrams per day. In the 3rd trimester of pregnancy, it's up to 400 milligrams per day. Over-the-counter progesterone is a 3% cream, so a 1/4 teaspoon is usually about 40 milligrams. Compounded 4% cream is a half cc is 20 milligrams, and 1 cc is 40 milligrams. So that's, when you see these percentages, sometimes even I get confused, and I just remember that a 4% cream is 40 milligrams per gram or cc. You can also do patches. I like patches a lot. I used to do creams, and I think some women respond beautifully to creams, but other women do really well with a patch. It's harder now to get it covered by insurance, and we now have the mini dot patches now. The dosing starts not at 0.025 but 0.0375. But the regular patch starts at 0.025, and that's what I start with, and I go up to 0.1 per day for the full dose, and I increase dose every 2 weeks, and I'll show you how to do that. And you monitor for symptoms of excess. You can decrease the dose and check saliva level in 4 weeks, and then monitor progress and recheck in 12 weeks. Symptoms of estrogen excess: breast tenderness, headaches, irritability or mood swings, anxiety or depression, puffiness and bloating, sleep disturbance or insomnia, and general malaise. Goal of therapy, If you're doing saliva, between 1.3 and 3.3. If you're doing urine, you will have the normal ranges there, and you want them to be in balance, and then progesterone 2 to 3,000. And you want a ratio of 1 to 500. But you always get ratios with these reports, whether it's saliva, urine, or blood spot. I like blood spot and urine, and I like urine the best at this point. You want them to be symptom-free, and you want their labs to be in a normal range. FSH, how do we diagnose menopause? FSH of 23 or greater, BHRT as hormones replace, should expect to see a fall in FSH. FSH of below 50 is a sign of tissue response and effective dosing. Clinical effects are still a better guide, always, because the levels don't always reflect the tissue level. You want to cycle progesterone. So once proper dosing levels are discovered, start to cycle progesterone in any patient with a uterus, regardless of age. If they're premenopausal, day 7 to 14 through 25. So some people will do progesterone day 14 through 25, and others feel that the progesterone is really required day 7 to 25. And it really depends on how the person feels around the time of their cycle. If they're postmenopausal, first 5 days of the month, no progesterone, or you can stop progesterone or really both hormones every 7 days. So Sunday is a day of rest for hormones. So there's 2 different ways that you can do it, but a lot of people will just do stopping progesterone day 5. Bias cream, estradiol, and estriol. You really don't want to do estrone. There's lots of good data on estriol. There's some good data on estradiol. And it comes in a 50-50 ratio. You can also do a 70-30 ratio. Sometimes women respond a little better to higher amounts of estradiol relative to estriol. Estriol is very protective and buffers against estradiol, so you always want some around. You start with a milligram and a gram of cream. So that's the starting dose. Okay, so that's what you order. And then this is what I do. So I start with 2 lines or 0.2 cc's for 2 weeks. And then the patient will increase 0.2 cc's every 2 weeks. And then you monitor for symptoms. And then you reduce the dose and then get a saliva test. So basically what you're doing is you're saying, okay, I'm preloading you with progesterone for 2 weeks, and then I'm starting with a very low dose of estrogen, and I build every 2 weeks until your symptoms go away. And then if you happen to increase the dose again, if the symptoms return, you know that the dose just prior is the correct dose. That's where they stay in balance, and then that's when you get your test, whether it's saliva, urine, or blood spot. So the notion is that you track their symptoms, and once their symptoms disappear and then return, you back off a little bit. And that's when you want to get your test. And that's how I dose find with this. It's actually pretty simple. So you keep a baseline of progesterone, and then you dose find with the estrogen. And patients do really well with this model. And it keeps them at a lower dose. So old school, so if you're going to use blood, but you really can't do that with cream, I think in terms of usefulness, blood spot's better than saliva, and urine is probably better than blood spot. And when I say urine, there's a reason why I reached out to Precision Analytics. I think they're quite a good company when it comes to measuring hormones. So that's why you receive urine kits for hormones from them. So how does the body dispose of estrogen? How does it break down in the liver? Well, estrogens are interconverted, and so estrone and estradiol are sisters, essentially, but that ultimately it's the estrone that's metabolized, and there's lots of discussion about the 2-hydroxyestrone or the 16-hydroxyestrone. The 16 is the one that converts into estriol, and there's some question about what is the correct ratio of 2 to 16. Again, when I pulled the literature on 2 to 16, there's as many negative studies as there are positive. I think it's important. I think because there are some positive studies and because it's relatively easy to help the body metabolize estrone with DIM, you just do it. But again, when you look at the role of quinones in particular, these are probably the ones that are more important, I think, and that's based on Dr. Cavalieri's work and some others, but it's primarily his work. So, and you can look at, sort of genetic issues like COMT, which helps drive methylation. So, you want to make sure that they're methylating appropriately. So system breakdown, P450, we just went over this, right? So P450 is phase 1. COMT and glutathione deficiencies are in phase 2. So you want to make sure that the liver is functioning normally. And that means starting with lifestyle issues first. Healthy diet, plenty of sulfur-containing compounds, pH is above 6.8 or so. So that you know the body is working normally. If there are genetic issues with MTHFR or COMT, you can always add back in some methyl groups, whether it's a methyl B vitamin or a SAMe or trimethylglycine. So all of that is pretty important. Glutathione deficiency, we've talked about, well, how do we raise glutathione? And certainly what lowers it, so oxidative stress, excess hormones, pesticides, solvents, pollutants, prescription meds. So we know how to deal with this too. That's why, aged garlic and alpha-lipoic are on the list, because they're quite good at raising glutathione. You want to promote the 2-hydroxy, DIM does it, and again, resveratrol and N-acetylcysteine, that's really more for the quinones. Flaxseed meal with the lignans, soy, I would say in very moderate amounts. Moderate exercise does it, and here again we have, what's the difference between men and women with exercise. If you really follow the literature, it seems that women do really well with moderate exercise. Kudzu, that's one of the supplements that I had you review, a higher protein diet, omega-3 fats, and then B vitamin support, especially methylated B vitamins. So there's some pretty straightforward and easy things to do to help the liver and the digestive tract dispose of estrogens. If they're developing breast tenderness, sometimes it can be from excess progesterone, because progesterone does convert into cortisol, and this is through the mineralocorticoid pathway and ultimately converting into aldosterone, and then also breast tenderness and edema, or breast edema and tenderness. If there are sleep issues, low or high estrogen can interfere with sleep. Progesterone will facilitate sleep, so when you take it, progesterone converts into really what's called allopregnenolone. It's an alpha-based pregnenolone, which then converts into GABA. So oral progesterone, 9% is converted in the liver to this allo or alpha-pregnenolone, 50 to 100 milligrams at night, in addition to topicals. So sometimes women need both, a little bit of oral on top of topical to get them sleeping and feeling rested. But if there's too much, it can be from an overconversion into cortisol, and I do see this. You can check DHEA levels. If low, then support them with 25 milligrams at night to slow this reaction. Progesterone can stimulate excess testosterone production, complains of acne or hair growth, treat with saw palmetto, and lower progesterone doses. If it's just excess with increased cortisol or testosterone, it can lead to some insulin resistance, weight gain, or fat storage, increased appetite and carb cravings. So you really need to work with all of these together and balance estrogen, progesterone, and testosterone. So progesterone can off-balance an individual just like estrogen can. If there's breast tenderness and it's from estrogen excess, reduced by 20%. If it's from progesterone, reduced by 50%. Or if it's too low, increased by 50%. And you need DIM and bowel clearance, so diindole methane, resolve constipation, add flax meal, calcium D-glucarate. Calcium D-glucarate prevents the reabsorption of estrogen in the gut. So what's the basic BHRT protocol? This is something that you can just copy from the slide, because I'll give you these slides. And then I just use this as a handout. So progesterone must be initiated for 2 weeks before the estrogen is started. This is typically topical progesterone, 1 cc at bedtime. And then here's my protocol for topical estrogen cream or patch. And so you start weeks 1, 2, 0.2 cc's, weeks 3 to 4, 0.4 cc's, so on and so forth, up to 1 cc. and you wait until their symptoms disappear and then reappear. Once they reappear, you back down by 0.2 cc's. So let's say they felt great at 0.6 cc's, and then some symptoms reappeared at 0.8. You back them down to 0.6, and that's when you measure and see how close you got to reality. You can do the same thing with a patch. So they can cut the patch, and they can apply a new patch every 3 to 4 days, and then you dose fine with that as well. Obviously, the cream is a little bit better, but you can still do it with a patch as well. Reaching target by symptoms. So you want to monitor symptoms. You're to continue this course until you begin to experience any of the following. This is what I tell patients, and this is what I hand them. So here are the excess symptoms. This is the point at which you'll slightly reduce your estrogen dose by 0.2 cc's and maintain it for 4 weeks before getting some sort of test, whether it's saliva or urine or blood spot, and then to verify the hormone levels. And then you also want them to be on DIM, and if they're premenopausal, you certainly want them to cycle. And some people do this with postmenopausal as well, so day 7 to 25 or even 14 to 25. Day 1 is the first day of menses. If you're postmenopausal and have a uterus, you don't use progesterone days 1 to 5 of each month. If you do not have a uterus once balanced, you don't have to take progesterone on Sundays. So there's all sorts of ways of doing this, but this is how I do it. You can also do testosterone replacement in women. So topical testosterone is 0.2 to 2 milligram cream. You combine with estrogen once estrogen and progesterone levels are steady. You can also consider adding topical DHEA and pregnenolone, 5 to 10 milligrams of each topically daily as well. So what do we do with Barbara Hiltz? With our clinical strategy, you want to break her insulin resistance and manage cortisol and thyroid. That's Triad 1. You want to address gut immune axis. Triad 2, remember, she's got the presence of TPO antibodies. Assess for toxicity in Triad 4, and then balance estrogen progesterone after implementing 1, 2, and 4 because she has these other issues, especially with the Hashimoto picture. Dietary advice, we know what that is. You certainly want to get her on the portal. I think, get her going on a good diet. Here we have our progression for blood sugar and insulin management. Key concept, once again, you want to help her lose weight, so decrease inflammation. You want to do some thyroid support, but remember she's got TPO antibodies, so you're going to do selenium-methionine iodine, but you're not going to do a glandular. Support her ferritin. Some stress management, because we know she's got some elevated cortisol levels. If insulin's cravings and stress, then add some tryptophan for mood. Presence of TPO antibodies, we're going way back to Triad 1. I know it feels like a long time ago, but food allergies, that's Triad 2. Heavy metals, Triad 4. Chronic infections, we haven't addressed yet, but we will. And then stress. Hypothyroidism, does she have TPO antibodies? If yes, selenium-methionine, magnesium, sterols and stanols, or sterolins, excuse me. And you need to get her off any glandulars that she might be on. If presence of TPO antibodies, can't use glandulars. Is there GI inflammation? If yes, cat's claw and oligomanganese copper, known toxins as well, add curcumin. We've seen this. And she does, because we know she's got candida and mercury. Presence of autoimmune disease, if yes, check for heavy metals, viruses, food allergies. So you're probably going to want to do a food panel. There's a few good companies in that regard. I think Dunwoody Labs, ELISA Act, or MRT. Those are reliable food sensitivity panels. So we know she's got mercury. She's likely holding on to her candida because of the mercury. What do we do if you find some viruses? Epstein-Barr, HHV6, HSV1 and 2, CMV. You want to add some antiviral herbs. I like a company called Raintree. Raintree has a product called A-V. A-V is 3 caps twice a day. You can also do astragalus, 1 cap 3 times a day. Huperzine, GPC, ALC, 2 caps twice a day to decrease neurologic inflammation. Then even minocycline for the same. Does she have organic chemicals? We know what to do. If she has access to a sauna, I would recommend using that. Certainly because of her mercury, you definitely want to do DMSA or IMD or both. I think EDTA2 as a suppository would be fine with her. So here are your additional choices. You know about this. So she is a 1, 2, 4, 5. So what would you do with someone like her? Get the carbs out of the diet, balance her lifestyle issues, get her prepped and ready to start some hormone replacement. But, you know, she's got a lot of stuff. She's got stress. She's got autoimmunity. She's got food sensitivities. She's got candida and mercury. You're going to have to clear all of that up. You're really going to have to focus on 1, 2, and 4 before you get to Triad 5. But I can tell you, you will find it's a lot easier to balance Barb's hormones if you focus on 1, 2, and 4 first, and then you do DIM and progesterone and bias testosterone, and she'll do great. I guarantee she'll do great with this very simple regimen, and I think this makes it really easy when you're doing hormone replacement. But she probably came in thinking she just needs hormones, and sometimes it's more complicated than that. But hopefully you can see how all these pieces are finally pulling together, that when you listen to an individual story, you can hear the complexity in their story. You can begin to zone in on, well, I hear Triad 1, I hear Triad 3, I hear Triad 2, I hear Triad 5, and you begin to pull this plan together. So you have lots of tools now with respect to sort of that systems biology approach of the interactive effects, how they generate symptoms, and then begin to break patients down based on their labs and symptoms into these subdomains or subtypes that we call triads, and it makes it very easy to get these people better despite how complex they might be. And be very disciplined about triads, you know, because this is how the body tends to move. It's these interrelationships that appear. And it's a lot easier, I think, than, you know, the functional medicine matrix, which doesn't give you this level of guidance or simplicity. And there's an elegance to organizing information in this way that I have found to be extremely helpful in my practice. It's why we've programmed the whole online system to provide support with respect to you know, diet and exercise. And lifestyle issues with the lifestyle guidance portal, in addition to the actual systems biology approach. So I hope that the series of lectures were helpful for you. Begin to organize your thinking, break patients down, give you lots and lots and lots of practical information about how to deal with complex patients in a fashion that makes it straightforward for you and for them too. I know we've covered a lot of information so far, but you finally sort of crossed a major finish line in 6210, but for, you know, the entire master's program, because this is a really important course for you, and I think that this was a good start with respect to seeing what is systems biology from a clinical perspective.